We'll talk about salivary glands now, and you know that the function of salivary glands is to produce saliva. When we eat or when we think about food, that's when saliva gets produced. For me, what gets my saliva going are sweets. I have a sweet tooth, and that's what gets my saliva going. And the two most favorite sweets of mine, one is a Gujarati sweet known as Mohan Thal. That's the one on the left. And the one on the right, when I was in Bangalore doing my fellowship, I developed a huge liking for Mysore Pak. The one which is laden with ghee, and that gets my saliva going. And the sad part about coronavirus, I got a coronavirus infection, and when I got it, I thought, well, now I can order outside food as well. Now I already have corona infection, but was the loss of taste. And with that, couldn't taste anything, and it was the worst period for me, which lasted for a month or so. Well, anyways, that was just the background for salivary glands. Let's talk about the actual conditions which are asked in the exam. The first one which I want you to know is a Staphne bone cyst. Now, the Staphne bone cyst, it's given in Bailey. This is the most common site for ectopic salivary tissue. Most common site for ectopic salivary tissue, and this is a cyst in the mandible. Now, this of course has to be differentiated. If you remember the previous module on oral cancers, I've told you about a dentigerous cyst as well, which is a cyst in relationship to an unerupted tooth. Here you can see it is just a cyst. There is no unerupted tooth there, that is how you can differentiate a Staphne bone cyst from a dentigerous cyst, right? So this is the first thing which you need to know. Then you can have a mucus retention cyst. A mucus retention cyst is just, it forms because of a blocked duct, and this is a mucus retention cyst of a minor salivary gland. You can just see a duct has got blocked and a cyst has formed here. So the management of a mucus retention cyst like this is excision, right? You simply excise the cyst. Now, another type of mucus retention and extravasation cysts are plunging ranulas and ranulas respectively, and we need to talk about them because they've been asked quite frequently in the exam. So first we'll talk about a ranula. The literal description of ranula is a frog's mouth, or a frog's belly, is a frog's belly. And this ranula, as you can see here, this is a mucus extravasation cyst. So that is what is given in Bailey. It is a mucus extravasation cyst involving the sublingual salivary gland. Right? So mucus extravasation cyst involving the sublingual salivary gland, that is a ranula. And here you can see that this is a cystic swelling in the floor of the mouth. It has a slightly bluish tinge to it. There can be a slightly bluish tinge to it, and because it has clear fluid inside it, because it is a cystic swelling and it has clear fluid inside it, transillumination can be done. Transillumination is positive. In fact, it is brilliantly transilluminant. And what are the other brilliantly transilluminant swellings which we know of? So transillumination, you can see in a hydrocele. This I've even demonstrated in one of the cases to you, how transillumination is done. You can see it in cystic hygromas. This I've covered in common swellings module, cystic hygromas, and in epididymal cysts. These are the epididymal cysts. And also a meningocoele. This is covered in the neurosurgery module, meningocoele. These are your transilluminant swellings which you should be aware of in addition to ranula. And any swelling which has fluid inside it, which sign can we elicit? Another sign which we can elicit is fluctuation. Any fluid-filled swelling, you will have fluctuation, positive, right? So this is how the patient presents. The management of a ranula is very important. It has been asked many, many times in the exam. The first thing which you need to know is that incision and drainage is contraindicated. Incision and drainage is contraindicated in case of a ranula. And why is incision and drainage contraindicated in case of a ranula? You can see here that this is the roof of the ranula. This is the roof of the ranula. Incision and drainage would be when I just incise it. Now, if I incise it, I can drain out all the mucus. But what is going to happen that this incision which I've made is going to heal up, and when it heals up, then the mucus is going to form again. So very, very high recurrence rate if only incision and drainage is done. That is why it is contraindicated. The treatment options, the surgical treatment options for ranula are marsupialization, and you need to know what is the difference between marsupialization and incision and drainage. So marsupialization also, this is the roof of the ranula. I'm going to incise that, and after incising this roof of the ranula, I get two edges, right? These are the two edges which I get. Now if I suture these two edges on the side, that is marsupialization. So I'm just not going to leave these edges, I'm going to suture them on the side so that the mouth remains open. In marsupialization, the mouth will remain open, and that would prevent a ranula from recurring. Right? Or we can do excision of cyst, or we can do excision of cyst plus the sublingual gland. This is the preferred treatment option, excision of cyst and the sublingual gland. Two more questions which have been asked in the exam. What is the most common structure injured? Most common structured injured in ranula surgery, and which is the most common nerve injured during ranula surgery. So don't get confused between the two questions. Both have been asked multiple times in the exam. The most common structure injured is the submandibular gland duct, but the most common nerve injured is the lingual nerve. Right? So no confusion between the two questions. They both have been asked multiple times in the exam. So this was regarding a ranula. Now you can even have a plunging ranula. So a plunging ranula, unlike a ranula which was a mucus extravasation cyst, a plunging ranula is a mucus retention cyst. So this is the first difference. It is a mucus retention cyst involving the sublingual and the submandibular salivary gland. Involving the sublingual and the submandibular salivary gland. So the swelling, there is an intraoral swelling like you have in a ranula, plus you have a swelling in the neck. So basically the swelling goes through the floor of the mouth, and you have a swelling in the oral cavity and you have a swelling in the neck. So it's kind of like a dumbbell shaped swelling. One portion is intraoral, one is in the neck. Again, it's a fluid filled swelling, so fluctuation is going to be there. So that is a plunging ranula. Now the management of plunging ranula, according to latest Bailey, the management of plunging ranula according to latest Bailey is surgery. Now surgery would be excision of intraoral swelling plus the sublingual gland plus aspiration of the neck swelling. So for the neck swelling, only aspiration is enough, plus aspiration of the neck swelling. That is the treatment for a plunging ranula. So you should know the treatment for ranula and plunging ranula. Both have been asked quite frequently in the exam. The next benign condition. So we are talking about the benign conditions of salivary glands till now. We are not talking about the tumors. We'll talk about them in some time. The next benign condition which I want you to know is a parotid abscess. Now parotid abscess, it is an uncommon site for an abscess. It is usually seen in immunocompromised patients. It is usually seen in immunocompromised patients, and it is usually staph or strep infection which can give rise to this parotid abscess. Now, parotid abscess, the clinical features of a patient with parotid abscess, patient is going to come with a painful parotid swelling. Patient is going to come with a painful parotid swelling. There can be fever. There can be redness, right? Now, when we examine the patient on examination, you can see that there can be redness here. There can be redness present here. But fluctuation, you know that an abscess is also a fluid-filled cavity, but fluctuation is a late sign in a parotid abscess, right? This is very important. Fluctuation is a late sign because you have such a tight fascia around it that fluctuation is a late sign. And the clinical importance of this I've told you in breast abscess and ischiorectal abscesses. We don't wait for fluctuation to occur. Don't wait till fluctuation. By that time it will be too late. Start acting beforehand. Okay. So fluctuation is a late sign. Just to recapitulate, what are the other abscesses where fluctuation is a late sign? We have discussed it is a late sign in breast abscess, in ischiorectal abscess, in palmar abscess and plantar abscess, in addition to parotid abscess, right? So these are the abscesses where fluctuation is a late sign. Don't wait till fluctuation to occur. The management is of course incision and drainage, but one peculiar thing which I want you to know here is the Hilton's method of draining an abscess. Is the Hilton's method of draining an abscess. Now, I know as interns, all of you must have drained abscesses in the emergency or during your internship. And you know that abscesses have loculi in it. And unless you break the loculi, the pus is not going to come out. But there are certain areas where we need to be careful, like the parotid region, because you will have the facial nerve there. So, Hilton's method states that whenever we are draining an abscess, close to an important neurovascular bundle. Whenever we are draining an abscess close to an important neurovascular bundle, always open your forceps parallel to the neurovascular bundle, right? So if this is the facial nerve, I open my forceps parallel to the neurovascular bundle, never perpendicular to it. Don't open perpendicular because then you can injure the neurovascular bundle. Okay, you can injure the neurovascular bundle. So that is the importance. Always remain parallel to the neurovascular bundle. What is the other area where Hilton's method is of importance? Even in axillary abscesses, even in an axillary abscess, this is important. You should follow the Hilton's method. So that is the management of a parotid abscess. So if you're asked in the exam, how will you make an incision for parotid abscess? In the fascia. Skin incision would be a vertical incision, but the fascia incision would be transverse, would be along the facial nerve to drain the abscess. Okay. Now, another thing which you need to know is another inflammatory condition is recurrent parotitis. This recurrent parotitis is seen in children between 3 to 6 years of age. It is seen in children between 3 to 6 years of age, and because of these recurrent attacks of parotitis, on an X-ray you will get a snowstorm appearance. On an X-ray you will see this snowstorm appearance on X-ray. The management of these patients is antibiotics for a long duration and repeated washouts of the gland. And repeated washouts of the gland. Another type of parotitis which is commonly seen in HIV positive patients is HIV parotitis. And in HIV parotitis, it is usually bilateral, and you can see multiple cysts. And you can see multiple cysts in parotid, as you can see in the image. And these multiple cysts, it gives a Swiss cheese appearance on imaging. It gives a Swiss cheese appearance on imaging. So these are the various infections which can be there pertaining to the parotid gland, right? One more inflammatory condition which you should know about is Kuttner's tumor. Although the name is of a tumor, but this is not a tumor. This is chronic sclerosing sialadenitis. Involving the submandibular gland. This is known as a Kuttner's tumor, chronic sclerosing sialadenitis involving the submandibular gland. Now, the final benign condition which we need to discuss is silolithiasis. Now, silolithiasis is stone formation in the salivary glands. Silolithiasis is stone formation in salivary glands, and this stone formation is more common in the submandibular gland. Submandibular gland stone formation is more common than parotid stone formation. This question has been asked multiple times in Viva and in the MCQ exam. The reason behind this is more viscous secretions of the submandibular gland and anti-gravity drainage. Of the submandibular duct. You know, the submandibular duct has to come from below upwards, and it has to go through the floor of the mouth. So anti-gravity drainage also leads to higher chances of stone formation in the submandibular gland. The most common composition has also been asked, and according to the latest Bailey, it is calcium phosphate. Calcium phosphate is the most common composition of salivary gland stones. Calcium phosphate is also the most common composition in parotid gland, correct? Parotid gland stones are also most commonly calcium phosphate. Now, 80% of these stones are radio opaque. 80% are radio opaque. You know, in gallstones only 10% are radio opaque. Salivary glands 80% are radio opaque, and kidney stones 90% are radio opaque stones. Fine. Now, the clinical features, how will the patient present and how will you suspect that the patient has silolithiasis? So, the classical presentation is a mealtime syndrome, right? This is the term which is written in Bailey, mealtime syndrome. You should know this. What exactly is this mealtime syndrome? So, this is the submandibular gland, and this submandibular gland has a stone here, right? Now, this patient has food which he or she likes quite a lot. So, when they have this food, you know that saliva is going to get produced. So, the saliva gets produced here, but saliva gets blocked because of the stone. So, because the saliva is getting blocked because of the stone, the gland is going to enlarge. So, the patient is going to come with a painful postprandial. Patient is going to come with a painful postprandial neck swelling, right? And this is going to last for 1 or 2 hours. Painful postprandial neck swelling after eating food. Patient is going to develop this swelling, and the swelling is gradually going to subside after a period of 2 hours or so. But after 2 hours, it's going to be time for the patient's next meal after 2 or 3 hours. And again, when the patient has something to eat, again the swelling is going to enlarge. So that's the typical presentation. A painful swelling after food, gradually subsides. Again, the patient has food. Again, the swelling comes up. The investigation of choice, very important. It has been asked multiple times in the exam, is a non-contrast CT scan. Again, to recapitulate, a non-contrast CT scan, I've told you, is the investigation of choice at 3 places. It is head trauma, salivary gland stones, and renal stones. Head trauma, salivary gland stones, and renal stones. That's where non-contrast CT scan is the investigation of choice. Now, how do we manage a patient with silolithiasis? If you have a patient, if the stone is less than equal to 4 millimeters in size, then endoscopic removal can be done. And endoscopic removal, we can use a Dormia basket. I have shown you a Dormia basket in the kidney chapter and in the gallbladder chapter. You can use a similar Dormia basket to retrieve this stone. If it is more than 4 millimeters in size, there are 2 approaches here. You can either break up the stone break up the stone using lithotripsy. Lithotripsy also I've discussed in kidney stones. You break up the stone using lithotripsy and then extract the fragments. And you extract the fragments, or you can do an open surgery and removal of the stone. So these are this is how we deal with the stone. Now, one more thing which we need to consider when we are dealing with the submandibular gland stones, that if stone is distal to the lingual nerve. So if the stone is distal to the lingual nerve, that is distal to the molar, then what we can do is we can directly make an incision over the duct. And mind you, it has to be a longitudinal incision, because if you make a transverse incision, if it heals, it's going to form a stricture. So I make a longitudinal incision over the duct, and we can extract the stone. And then we suture the duct using extract stone, and then we suture the duct using absorbable sutures. Right, that is what is written in Bailey. We suture the duct using absorbable sutures. The previous edition of Bailey said that you leave the duct open, but the latest edition says that you suture the duct using absorbable sutures. Now, if the stone is proximal to the lingual nerve, or close to the gland parenchyma, then you have two approaches. We can either do endoscopic approach, or we can do surgical removal of the gland and stone. But this is usually reserved if endoscopic approach fails. If the endoscopic approach fails, then only we carry out the surgical removal of the gland and the stone. And the final point which you need to remember, the most common structure injured during submandibular gland stone surgery is the lingual nerve. These nerve injuries are very important. The Central Institute, the INI CET exams are giving a lot of importance to these nerve injuries, so you should know about them. So we've covered the benign conditions of salivary glands. Let's now talk about salivary gland tumors. And in salivary gland tumors, there is a very important table which I want you to know. And this was asked in last year's UPSC exam as well. And another advice which I would like to give all of you is that this UPSC exam is very important. What we are seeing is that most of the topics which are being asked in the UPSC exams are being repeated in the Central Institute and the NEET exams as well. So don't miss out on the UPSC exam, even if it's just for practice. Do appear for that exam. So this table says that we have percentage of benign tumors, and we have percentage of malignant tumors. If we have percentage of benign tumors, percentage of malignant tumors, and we talk about parotid gland, 90% tumors are benign, only 10% tumors are malignant, right? Submandibular gland, it is 50-50, 50% benign, 50% malignant. Sublingual gland, 20% tumors are benign, 80% tumors are malignant. And minor salivary glands, only 10% tumors are benign, 90% tumors are malignant, right? So what we infer from this table and the statement which all of you should remember, larger the salivary gland, more is the percentage of benign tumors. Smaller the salivary gland, more is the percentage of malignant tumors. Right? So please remember this statement. This is very important for the exam. Okay. Let's talk about parotid gland tumors now. Right? So we are talking about parotid gland tumors. And there are certain one-liners which you need to know. Before I tell you about the one-liners, in general, I want to tell you how will a patient with a parotid swelling present. So if you get a patient with a parotid swelling, this is the typical presentation. Patient is going to come with a swelling on the side of the face, and it is going to lift the ear lobule. That is the classical description, that it lifts the ear lobule. It lifts the ear lobule, okay? Now, you know that parotid gland has two lobes. It has a superficial lobe and it has a deep lobe, right? So, parotid has a superficial and a deep lobe. Most of the tumors are arising in the superficial lobe. Majority of the tumors are arising in the superficial lobe, and if there is a superficial lobe enlargement, this is how the patient presents: a swelling, and the angle of the ear lobule gets lifted up. But you should know that if deep lobe enlargement is there, if deep lobe enlargement is present, how can we find out clinically that the deep lobe is enlarged? This was a question which was asked in an exam 2 years back, and it's a very good question because it involves clinical skills. So how do you clinically know that the deep lobe of parotid is enlarged, right? So it's a very simple thing. Whenever you get a patient with a parotid swelling, always examine the oral cavity as well. Now, why am I examining the oral cavity? For two reasons. One is to look at the parotid gland opening, and the second is to see if the tonsillar fossa is pushed medially or not. So if the tonsillar fossa is pushed medially, if the tonsillar fossa is pushed medially, then it signifies that the deep lobe is enlarged, right? So this is a clinical sign. You should know about it. It has been asked in the exam. Okay. Now, parotid tumors. Let's discuss certain one-liners. What is the most common benign tumor of parotid? The most common benign tumor of parotid is pleomorphic adenoma. We're going to talk about this in detail. What is the most common benign tumor in children? In children, it's a hemangioma. What is the most common malignant tumor of parotid? The most common malignant tumor of parotid, this is mucoepidermoid cancer. This has also been asked in the exam. It is mucoepidermoid cancer. And what is the second most common malignant tumor of parotid? It is adenoid cystic carcinoma. This also we'll talk about in detail later on. And what is the most common bilateral parotid tumor? The most common bilateral parotid tumor is Warthin's tumor. So these are just one-liners. Let's talk about these tumors in details. These one-liners are frequently asked in the exam, so you should remember them. Now, pleomorphic adenoma is a very important topic both from your college exam, a short note is asked, and MCQs are also asked from pleomorphic adenoma. Pleomorphic adenoma is the most common tumor of salivary glands. So overall also, pleomorphic adenoma is the most common tumor of salivary glands. Of course, it is the most common tumor of parotid gland as well. Now, pleomorphic adenomas, it is a benign tumor. Which is slow growing. It is a benign tumor which is slow growing. If you look at the clinical features of this tumor, then this is more commonly seen in females as compared to males. It is commonly seen in females as compared to males. It is a slow growing, patient is going to come with a slow growing parotid swelling. Slow growing parotid swelling. One of the risk factors is radiation exposure. In this patient. Now, whenever a patient comes to you with a parotid swelling, how do we confirm the diagnosis? So, the investigation of choice in these patients is going to be an FNAC, fine needle aspiration cytology, is going to clinch the diagnosis for us. And the extent of the lesion, please remember, for all salivary glands, extent, MRI gives us better delineation than CT. MRI gives better delineation than CT. Now, if we talk about the pathology of pleomorphic adenomas, this is very important. And in the latest Robbins, there has been an update in the salivary gland chapter as well, where they've highlighted the gene mutations in some of these tumors. So, the gene mutation which is associated with pleomorphic adenoma is the PLAG1 gene, which is mutated. And in pathology, this is a tumor which has epithelial components, in a myxoid background. Epithelial components in a myxoid background, right? So let me just show you the slide and you will be able to correlate this with your second year, that you have this purplish stroma, the myxoid background, and you will have these pinkish elements interspersed between them, the eosinophilic elements interspersed between them. Those are the epithelial components. In fact, we all used to joke around that this was one slide which you could identify even without putting under the microscope. And I had so many of my friends, I'm sure a lot of you must have also done that. You must have noted down characteristics of what a pathology slide looks like rather than actually seeing it under the microscope. And in the professional exams, one of my friends got a case of pleomorphic adenoma, and even without putting the slide under the microscope, he just looked at the slide against the light and he wrote down pleomorphic adenoma. But unfortunately, the external examiner caught him. Now, the external examiner was also in a jovial mood, and he just came towards my friend, just tapped him on the shoulder and said that, I know you know the diagnosis, but at least just put it under the microscope. So that's the slide of pleomorphic adenoma. There's one more pathological feature which I want to tell you. The pleomorphic adenoma, the growing edge has finger-like projections. The growing edge has finger-like projections. And these finger-like projections are the ones which are responsible for, finger-like projections are the ones which are responsible for increased recurrence rate in this tumor, right? If these finger-like projections are left behind, there can be a very high recurrence rate in pleomorphic adenomas. The management of pleomorphic adenomas, the minimum surgery for parotid gland, it is not enucleation of the tumor. If I enucleate the tumor, then very high recurrence. So the management is superficial parotidectomy. That is the minimum surgery. In parotid, we will do a superficial parotidectomy. I'll talk about superficial parotidectomy in detail later on. So that is the treatment. Now, sometimes pleomorphic adenoma can get converted into a malignant tumor, can undergo malignant conversion. And what are the points in history and examination which would tell you that a pleomorphic adenoma has undergone malignant conversion? So, rapid increase in size, a painless swelling becoming into a painful swelling, involvement of facial nerve, involvement of lymph nodes in the neck, and ulceration. So these are the findings which would tell us that a previously benign lesion has now undergone a malignant conversion. And if a pleomorphic adenoma undergoes a malignant conversion, it is known as a mixed malignant tumor. It is known as a mixed malignant tumor or carcinoma X pleomorphic adenoma, or carcinoma X pleomorphic adenoma, right? Now, if you have a malignant tumor of the parotid, management is again surgery, and this would be then followed up with radiotherapy. Surgery followed by radiotherapy. Now, in the previous editions of certain books, it was also written that if there is a second benign recurrence of pleomorphic adenoma, then also it is an indication for radiotherapy. But these days, primarily radiotherapy is reserved for malignant tumors. Once you've resected, then you're going to give radiotherapy there. So this is regarding pleomorphic adenomas. Warthin's tumor is the second most common. It is the second most common benign tumor of parotid, or the second most common tumor of parotid. It is a tumor which is exclusively seen in the parotid. It is exclusively seen in the parotid gland. And 10% Warthin's tumors can be bilateral, and that is why it is the most common bilateral parotid tumor also. Now, this Warthin's tumor, if we talk about the risk factors for Warthin's tumors, you have smoking and radiation exposure are the risk factors. Smoking and radiation exposure are the risk factors. If we talk about the clinical features, this is much more common in males as compared to females. Unlike pleomorphic adenoma, which is more common in females, Warthin's is more common in males as compared to females. And this is typically seen between the 5th to the 7th decade of life. It is seen typically between the 5th to 7th decade of life. And again, it is going to come as a slow growing parotid swelling. It will be a slow growing parotid swelling, and this usually involves the lower half of parotid, or it involves the tail of parotid. Commonly involves the tail of parotid, and sometimes painful. Sometimes it can be painful as well. So these are the clinical features with which the patient is going to present. We've already discussed the investigation of choices. FNAC, to figure out the extent, I've already told you MRI is better than CT. Now, if you look at the histopathological features of Warthin's tumors, what do we get in histopathology? This has been covered by Dr. Illa, but just quick recapitulation. So histopathology of Warthin's tumor, you will get a double layer of cells, right? You can see double layer of cells. You will see cystic spaces. So because we see cystic spaces, this is also known as adenoma lymphomatosum. Adenoma lymphomatosum is another name for this, and this highlights the third pathological feature as well. Lymphomatosum means there is a lymphoid infiltration. There is a lymphoid infiltration. You can see all these blue cells. These are the lymphocytes, or lymphocytic infiltration or is also seen. These are the histopathological features of Warthin's tumors. The management of Warthin's tumors is, again, minimum surgery for parotid is superficial parotidectomy. Okay. So this was regarding pleomorphic adenomas and Warthin's tumors. The other swellings, before I talk about the malignant swellings, there's another term which you should know. This is a benign lymphoepithelial lesion. Benign lymphoepithelial lesion, or BLEL. It is a benign tumor. This is caused by cytomegalovirus. So you should know this. And another name for benign lymphoepithelial lesion is Godwin's tumor. The management is excision, and if malignant change is there, if this tumor undergoes malignant change, it is known as, if malignant change is there, it is known as an eschimoma. It is known as an eschimoma. The benign one is known as Godwin's tumor. If it undergoes malignant change, it is known as an eschimoma. Now let's talk about the malignant tumors of parotid. The malignant tumors, you have mucoepidermoid carcinoma, mucoepidermoid cancer. This is the most common malignant tumor. Most common malignant tumor of parotid is mucoepidermoid carcinoma. Radiation exposure is a risk factor. Radiation exposure is a risk factor in these patients. According to the latest Robbins CRTC1 MAML2 gene fusion, CRTC1 MAML2 gene fusion is responsible for this tumor. I told you latest Robbins has added the genetic mutations of these salivary gland tumors, so I'm just trying to incorporate them here. CRTC1 MAML2 gene fusion, and this can be seen during infancy also. Can be seen during infancy. The diagnosis of mucoepidermoid cancer, again FNAC will make the diagnosis. Extent will be by MRI, and the management is surgery followed by radiation. I will tell you how do we operate malignant tumors of parotid as well. When I talk about parotid surgery, I'll cover that aspect as well in just 2 minutes. Another tumor which you should know about is adenoid cystic carcinoma. Adenoid cystic carcinoma, I told you this is the second most common malignant tumor of parotid. This is the second most common malignant tumor of parotid. And adenoid cystic carcinoma, the telltale feature of adenoid cystic carcinoma, the clinical feature, patient is going to come with a swelling which is extremely painful. And the reason why this swelling is extremely painful is because these tumors show PNI. PNI is perineural invasion. PNI is perineural invasion, and because of perineural invasion, these tumors are extremely painful. I've taught you, and in pathology, Dr. Illa has also covered what are the other tumors where perineural invasion is an important prognostic factor. So the other tumors where perineural invasion is important is P for perineural, P for prostate, P for perineural, P for pancreas, breast, right? And I've also told you in adenoid cystic tumors, these are the places where perineural invasion is important. And because of this perineural invasion, there is also a very high recurrence rate in these patients. There is also a very high recurrence rate. Investigation of choice is FNAC. Extent is by MRI. Management is surgery followed by radiotherapy. Management is surgery followed by radiotherapy. And the typical histopathological features. So histopathological features, I've already told you that there is perineural invasion and you get these spaces, right? You get these cystic spaces in between and it resembles a Swiss cheese pattern. If you've seen Swiss cheese, there are these gaps or holes in between. So similarly, the slide looks like a Swiss cheese. So Swiss cheese pattern is seen in adenoid cystic cancers. So this was all regarding parotid tumors. Before we move on to other salivary gland tumors, let's talk about parotid surgery. It is a very, very important module, parotid surgery. Lots and lots of questions are asked. So parotid surgery, the incision which is used is known as the lazy S incision. This has been asked multiple times. Lazy S incision is also known as modified Blair's incision. Lazy S incision is also known as modified Blair's incision. BLAIR, Blair's incision. Okay. Now you can see this S-shaped incision. I've already told you the precaution which we need to take. This part of the incision should be at least 2 finger breadths below angle of mandible. Why? In the oral cancer module, I've already covered. Why? Because we want to prevent injury to which nerve? Prevent injury to marginal mandibular nerve. We want to prevent injury to the marginal mandibular nerve. That is why at least 2 finger breadths below. I'll tell you about the various nerve injuries following parotid surgery as well. Okay. Now, during parotid surgery, also we use bipolar cautery. This I've told you in general surgery also. Wherever we are operating close to vital nerves, we should use a bipolar cautery to prevent injury to vital structures. Okay. Fine. Now, what are the types of parotid surgery before we talk about the complications? So, what are the types of parotid surgery? I've already told you that the minimum parotid surgery is a superficial parotidectomy. The minimum parotid surgery is a superficial parotidectomy where we just remove the superficial lobe of parotid. If superficial plus the deep lobe of parotid are involved, if the superficial plus the deep lobe of parotid both are involved by the tumor, then we need to carry out, then there are two options. Then we either carry out a total conservative parotidectomy or we carry out a total radical parotidectomy. Then we do a total conservative or a total radical parotidectomy. Now, total conservative parotidectomy will be superficial plus deep lobe. Both are removed, but we save the facial nerve. So, this is very important. Total conservative is when we are going to save the facial nerve, but superficial and deep lobe both will be removed. Total radical parotidectomy is superficial plus deep lobe, superficial plus deep lobe plus facial nerve. FN is facial nerve is sacrificed. If you sacrifice the facial nerve to remove the tumor, then it becomes a total radical parotidectomy. And if you're sacrificing the facial nerve after the surgery, a cable graft is done to bridge the gap. Whatever portion of facial nerve you removed, to bridge the gap, you will use a cable graft. And cable graft, so for this cable graft, you need to remember that the best nerve available is the sural nerve. The best is the sural nerve, which is used for this purpose, but the most commonly used, which has been written in Bailey, is the greater auricular nerve. That is the most commonly used. And to suture the cable graft, nerve repair, which suture material is used, I've covered in general surgery. N for nerve, N for nylon. N for nerve, N for nylon, which is a non-absorbable synthetic monofilament suture. Right? So these are the types of parotid surgery. There's one more which is written in Bailey, very important. That's a new term that is known as extracapsular dissection of parotid. Extracapsular dissection of parotid. So extracapsular dissection is reserved for benign tumors. It is reserved for benign tumors, and what you need to know is it does not affect oncological outcomes. So it does not affect the oncological outcomes, means the cancer treatment is not, or the tumor treatment is not affected in any which way, but there is less risk of, the advantage of this extracapsular dissection is less risk of facial nerve injury. There is less risk of facial nerve injury and less risk of Frey's syndrome, which I will just cover in a couple of minutes. Frey's syndrome is also very important. So this is extracapsular dissection of the parotid gland. So let's talk about the complications of parotid surgery. Invariably in every central institute exam, a question regarding this topic is being asked. So this is a very, very important topic, the complications of parotid gland surgery. So obvious complications are hemorrhage can be there, infection can be there. There can be injury to the nerves. This is the most important one which is being asked, injury to the nerves. Now, injury to the nerves, what are the various nerves which can be injured? You have the marginal mandibular nerve. You have the marginal mandibular nerve or the ramus mandibularis. This I've already highlighted in the oral cancer module when I was talking about neck dissection. This is the branch of the facial nerve which supplies the angle of the mouth, and if this nerve is injured, there is drooping of angle of mouth. There is drooping of angle of mouth or a crooked face on that side. And I also told you about Sylvester Stallone, Sharat Pawar and Jeffrey Boycott having that kind of a facies when they speak, right? I also told you in that module, how do we prevent injury to the marginal mandibular nerve? We should at least have the incision at least 2 finger breadths below the angle of mandible. The other one which you should know about is the greater auricular nerve. Now, the greater auricular nerve, if it is injured, this was asked last year in the AIMS exam. The greater auricular nerve, if it is injured, there will be anesthesia. Anesthesia over the area of the beard or the angle of mouth, right? So the typical question which you will get in your exam is that a male patient undergoes parotid surgery, and after a few months when he's shaving, he has no sensation. So no sensation when he's shaving is because of injury to the greater auricular nerve, right? Of course, there can be facial nerve injury. There can be facial nerve injury which can be there, and one needs to identify the facial nerve trunk during parotid surgery. That is very important, and Dr. Manisha has covered in great detail what are the various pointers towards the facial nerve trunk during parotid surgery. But just to recapitulate the pointers, the most important is the tragal pointer. The most important is the tragal pointer, also known as the Conley's pointer. Also known as the Conley's pointer. And so the nerve is 1 centimeter inferior and deep to this Conley's pointer or tragal pointer, and this is the most important pointer which we use during surgery to identify the facial nerve trunk. You have the styloid process. The styloid process, the nerve is superficial to the styloid process. Nerve is superficial to the styloid process. You have the posterior belly of digastric. The posterior belly of digastric also can point towards the facial nerve trunk. And retrograde dissection, that means you identify the branches. Retrograde dissection, that means you can see the branches which have been marked here. So you identify one of the branch and you trace it back to the facial nerve trunk. That is retrograde dissection. This is not routinely done. This is only done in cases where we are doing a reoperation and there is a lot of fibrosis. So you identify any one trunk, any one branch, and you trace it back. That is retrograde dissection. Also these days, nerve stimulators are being used during surgery. Nerve stimulators and nerve monitors are being used during surgery to identify the trunk, but there should not be an over-reliance on these stimulators and nerve monitors. One should know these pointers and should be able to clinically identify the nerve trunk during surgery, right? So facial nerve injury can also be there. Now another very important complication is Fraze syndrome. This has been asked many times. A short note has also been asked in the college exams, and lots of MCQs have been asked. Fraze syndrome is known as gustatory sweating. Fraze syndrome is known as gustatory sweating. Clinical features would be, clinical features of Fraze syndrome, patient will have sweating over the region of parotid, sweating over parotid region. When patient eats, thinks about food, that is when the patient is going to have sweating over the region of parotid. Okay. Now, when such a patient comes after parotid surgery, although the history itself is very typical of the condition, but to confirm the diagnosis, we do a starch iodine test. we do a starch iodine test, that is the confirmatory test. So this is what we do. This is the starch iodine test. We are just going to paint iodine over the parotid region and we let it dry. We let it dry. Then we sprinkle starch over it. Image B, you can see we sprinkle starch over it. And then we give the patient whatever food he likes, right? And when the patient has that food, the saliva is going to get stimulated and there will be sweating over the region of the parotid. And you know that when starch reacts with iodine, it is going to turn purplish. So this is a positive starch iodine test. This is how we confirm the diagnosis. Now the question is, why is this syndrome developing? So the nerve implicated, this has been asked many times in the exam, is the auriculotemporal nerve. And to be precise, it is the postganglionic parasympathetic fibers, which are implicated. So please remember this, postganglionic parasympathetic fibers are the ones which are implicated. So now what happens is that auriculotemporal nerve is stimulating the parotid gland to produce saliva normally. Now what we've done, you know that there is a superficial lobe, there is a deep lobe, and you have this nerve. So let's imagine that this is the skin, my hand is the superficial lobe of parotid, and this is the nerve. Okay, this is the skin, my hand is the superficial lobe of parotid, and this is the nerve. Now I've done a superficial parotidectomy. I do a superficial parotidectomy. The nerve fibers still are there and the skin is still there, and there is nothing between the nerve fibers and the skin. So if these nerve fibers which were supplying the gland, now they grow and they start supplying the skin, right? So now they start supplying the skin over the parotid region. So whenever the patient eats good food or thinks about good food or smells good food, this nerve is now going to stimulate the skin glands and there is going to be sweating. So it is due to the regeneration of these postganglionic parasympathetic fibers, and they will now start supplying the skin overlying the parotid region. Okay. So mind you one thing, if these postganglionic fibers are injured, if the surgeon injures them during surgery, then there will be no Fraze syndrome. Okay. Only because these are left behind, that is why Fraze syndrome can develop. I've already told you how to clinch the diagnosis and how do we manage such patients. The management of these patients is antiperspirants. So the antiperspirant stick which is applying in the underarm, you tell him to apply it here as well. Of course, not the same one, but he can use an antiperspirant in this region. That is one of the ways to control it. But the most common method to control it is Botox injections, botulinum toxin injections, but they have to be repeated multiple times. The definitive surgery, like I told you, if I remove the nerve or if I cut the nerve, then this will stop. So the definitive surgery is a tympanic neurectomy. The definitive surgery is a tympanic neurectomy where you cut the auriculotemporal nerve and this problem is going to subside. Okay. Another thing which you need to know is how do we prevent Fraze syndrome from developing. So in the first hand, we should prevent Fraze syndrome. So one of the methods which I told you is extracapsular dissection of parotid. Which reduces the incidence of Fraze syndrome dramatically. The second way to reduce the incidence of Fraze syndrome, I told you that my hand was the superficial lobe of parotid, this is the skin and this is the nerve. Now I've done a superficial parotidectomy and there is nothing between the nerve and the skin. That is why the nerve is growing up till the skin. But if I put some muscle or if I put a flap in between the nerve and the skin, then the nerve cannot grow up till the skin, right? And Fraze would be prevented. So how do I prevent it? I can prevent it using a sternocleidomastoid or a digastric muscle flap. A sternocleidomastoid or a digastric muscle flap to cover the parotid bed. to cover the parotid bed. So this is how we prevent Fraze syndrome. Fraze syndrome is a very important topic from the point of view of your exam. The final complication which you need to know is a parotid fistula. Now parotid fistula can either be with the gland or via the duct. If a fistula forms through the gland, it is a low output fistula. And usually it heals spontaneously. But the fistulas which are associated with the duct are high output fistulas, and spontaneous closure is uncommon. So for a high output parotid fistula, the management is going to be surgery. And the name of the surgery, you can just remember the name. The name of the surgery is Newman and Seabrook's procedure. Where we ligate the fistulous tract. So Newman and Seabrook's procedure would be done in these patients. So these are the various complications following parotid surgery, and I've told you about parotid tumors. Of course, recurrence can also be counted as one more complication. Now, a submandibular gland swelling or submandibular gland tumors is what we need to discuss. I've already told you a submandibular gland swelling will occur in the submandibular triangle, also known as the digastric triangle. Now, a submandibular swelling can either be a lymph node or it can be the gland. So clinically, how do we differentiate whether it is a lymph node or a gland? And this is again a very important clinical question. So the differentiation is by bimanual palpation. You can see here bimanual palpation, 1 or 2 fingers inside the mouth and 2 fingers outside. If bimanually palpable, if the swelling is bimanually palpable, it is gland enlargement. If it is not bimanually palpable, it is lymph node enlargement, right? And this bimanual palpation is felt because of the extension of the deep lobe of the submandibular. There is a portion which can be felt by bimanual palpation. So this is how we differentiate a lymph node from a gland enlargement in the submandibular triangle. You should know about this. Now you should know that the most common tumor of submandibular gland is a pleomorphic adenoma. We've already discussed everything regarding pleomorphic adenomas. And the most common malignant tumor of submandibular gland is an adenoid cystic carcinoma. So adenoid cystic was the second most common malignant tumor in parotid, but here it is the most common malignant tumor of parotid. The management would be, so investigation of choice would be FNAC. The management of all submandibular gland tumors is submandibular excision. And if malignant, then patients are given radiotherapy as well. Now, when we are doing a submandibular gland excision, what are the various, so this is just an image showing submandibular gland excision. What are the various structures which can be injured during submandibular gland surgery? This is again a very important question which has been asked in the exam. The structures which can be injured are the marginal mandibular nerve. We've been discussing about this quite a lot. Marginal mandibular nerve. Then you can have lingual nerve. You can have hypoglossal nerve. So these are the 3 nerves which can be injured: lingual, hypoglossal and marginal mandibular. Then you can have the anterior facial vein which can be injured. And the facial artery which can be injured. So these are the vessels which can be injured during submandibular gland surgery. You should know about these, right? Now, a few lines regarding sublingual tumors. You know, in sublingual gland, almost 80% are malignant, only 20% are benign. The most common tumor here itself is adenoid cystic carcinoma, is adenoid cystic cancer. That is the most common tumor here because majority of the tumors are malignant. For minor salivary glands, again the most common tumor for minor salivary glands is also adenoid cystic carcinoma. You know that 90% minor salivary gland tumors are malignant. And one more question which has been asked, what is the most common site of minor salivary tumors? This is the hard palate. So hard palate is the most common site where minor salivary gland tumors can form. But one thing, the most common tumor of hard palate I covered in the oral cancer module is squamous cell carcinoma. Most common tumor of hard palate is squamous cell carcinoma. But the most common site of minor salivary gland tumors is also hard palate. So there are two different statements. Don't get confused between the two. This was regarding salivary gland tumors, which you should know about. Now let's just do some questions. I've told you these nerve involvements are very common. They were asked last year in the AIIMS exam. They were asked this year in the INI CET exam. I expect them to be asked in future as well. Now anesthesia in the axilla post MRM. You know the nerves implicated are the intercostobrachial nerves, ICBN, the most common nerve injured following MRM. Then anesthesia while shaving post-parotidectomy. I've already told you this is the greater auricular nerve. Shoulder dysfunction after neck dissection. This also we've discussed in the previous module. This is the spinal accessory nerve that got cut out. Spinal accessory nerve is the one with shoulder dysfunction. Chronic inguinal pain after open inguinal hernia surgery. That is the most common nerve which gets entrapped in the mesh. The most common nerve which gets entrapped in the mesh is the iliohypogastric nerve. Ilioinguinal is the most common nerve which gets cut during open surgery, but entrapped is iliohypogastric. Drooping of angle of mouth, marginal mandibular nerve. So these are some of the common nerve injuries. You should remember them. Very important topic for the exam. True and false regarding salivary gland stones. Most common composition is calcium phosphate. This is true. Submandibular silolithiasis is more common. True. 80% are radiolucent. False. The 80% are radio-opaque. Stones proximal to the lingual nerve cannot be removed intraorally. This is also false. I've told you that first these days we try endoscopic removal only intraorally. If that fails, then only excision is done. So in the latest INI CET exam, what they have done is that the typical PGI pattern where you have to choose multiple correct answers, they've made it much easy for you. What they've done is they will say you have to choose one option, A, B, C correct, right? Or A, B correct, or B, C, D correct. So they'll give options like this. So it's become much easier. You know, in this one, A and B are the correct statements. All of the following structures are associated with submandibular gland except lingual nerve, we know yes. Hypoglossal, we know yes. Anterior facial vein, we know yes. Greater auricular is with the parotid gland, not with the submandibular gland, right? So that brings us to the end of this module. What I want you to know for final year students, what are the important topics? Final year students, you can get a short case of a salivary gland swelling. The examination points are pretty much similar to the oral cancer case which I've covered. So you go through the examination. Frey's syndrome is very important, short note. Pleomorphic adenoma is a very important short note. And complications of parotid surgery. Complications of parotid surgery is very important. Of course, ranula is a super important topic. Sometimes silolithiasis is also asked as a short note in your college exams. So these are the 5 short notes which you need to prepare from this topic. If you have any doubts regarding the surgery modules when you're solving them, if you have any questions, you can always contact me on my social media profiles. The best place is Instagram, where my profile is left-handed surgeon. left-handed surgeon. If you have any questions, post them here or on the Marrowlinks group on the Facebook, or on Marrowlinks group on Facebook, and I'll be happy to answer your questions.